This is an introductory video on anaesthetics for medical students. We will look at airway equipment, the anaesthetics machine, and anaesthetics drugs. Anaesthetists use a range of equipment in order to maintain a patient's airway. This is called a Guedel, also known as an oropharyngeal airway. It's inserted into the mouth, and its purpose is to stop the tongue from falling back and then causing an airway obstruction. The different colours indicate different sizes, ranging from the white being the smallest to the red being the largest. Next we have an endotracheal tube, also known as an ETT. These are inserted into the trachea via the mouth. The tracheal end has a balloon that is inflated, and this allows the tube to remain in place and enables ventilation to be administered from the top end. The next piece of equipment is known as a laryngeal mask airway, or an LMA. These sit above the trachea with the mask covering the larynx in a sealed system. This model is an example of those that have a tube sitting over the esophagus and enable the gastric contents to be expelled and removed safely in cases of reflux, thus reducing the risk of aspiration. Finally, we have what is called a laryngoscope, which is an instrument that is used for intubation or endotracheal tube insertion. It is used to lift the patient's tongue for a clear view of the larynx and for safe endotracheal tube insertion. It is important that patients are paralyzed with muscle relaxants during this procedure. Video laryngoscopes are used for patients who are difficult to intubate, such as those with unusual anatomy or those with a lot of subcutaneous tissue around the neck. The video end of the laryngoscope allows the user to get a clear view of the larynx on the screen, enabling them to safely intubate the patient. After securing the airway and making the patient unconscious, they are then connected to the anaesthetics machine, which is also known as a life support machine. First, the mouth is covered with a mask that is connected via tubes to a bag and a ventilator. An example of this can be seen when we connect the ventilator to this bag, which simulates a lung. When we turn on the anaesthetics machine, the bellows start to move, creating pressure gradients and enabling the bag to inflate and deflate, which is exactly what is happening to the lungs. We can input data to predefine the tidal volume and the rate. For example, we can see here that a tidal volume of 500 milliliters and a respiratory rate of 12 breaths per minute results in a minute volume of 2.6 liters per minute. We can add in other parameters, such as a peak end expiratory pressure, to help with oxygenation and the mode of ventilation. There are two ways to keep a patient asleep. One is via volatile agents, such as sevoflurane or isoflurane, and the other is via an infusion of TIVA, or total intravenous anesthesia, which involves administering an anesthetic drug such as propofol. The volatile method is most commonly used in the RD&E. When turned on, the substance flows into the system, into the ventilator, and through the pipes into the lungs. In the next part of the video, we will take a closer look at the monitoring on the screen with a real patient case. In this example of a real case, sevoflurane is the anesthetic agent keeping the patient asleep, as you can see here. The ventilation settings on the screen affect the bellows below. The tidal volume has been set to 350 milliliters per minute, with a respiratory rate of 14 breaths per minute. The inspiration-expiration ratio of the respiratory cycle has been set at 1 to 2. We then have the peak end expiratory flow, which has been set at 5 centimeters of water. We then have a yellow graph, which is a pressure trace, and then a green graph, which is a flow trace. The patient's compliance affects the relationship of these two traces. This second screen shows the heart rate, and in this situation you can see that the patient has atrial fibrillation due to lack of P waves and irregular QRS complexes. Below is the saturations trace, which shows the oxygen saturation of hemoglobin in the patient. Below that is a sevoflurane trace, and that tells us how much sevoflurane is in use to keep the patient asleep. The bottom trace is the end-tidal carbon dioxide trace. The number and the waveform both provide information about the patient's cardiac output, their lung perfusion, and the effectiveness of the ventilation. At the bottom of the screen, we can see the patient's blood pressure. Next to that, there is detailed information about the patient's airway pressures. And to the right, there is information about the end-tidal oxygen concentration. Fi refers to the inspired fraction of O2, which is how much oxygen is being breathed in and out. The last box has information related to sevoflurane. Anaesthetists use drugs in order to manipulate patients' physiology in real time. Usually, these drugs are short-acting and you can see the effects immediately. For general anaesthetics, the three drug classes that are needed are induction agents, muscle relaxants, and analgesics. We will now go through a few examples of drugs that are frequently used by anaesthetists. This white drug is propofol. It's an induction agent that is used to bring about unconsciousness within a patient. Next, we have fentanyl. It's similar to morphine in that it is an opiate, however it is synthetically derived. It's faster acting and has less side effects than morphine. This drug is suxamethonium, and it is a fast-acting muscle relaxant. It is an emergency drug that is used when the patient's airway can't be secured and it is important to ventilate them quickly. It tends to be used in rapid sequence induction. This drug is ephedrine. It is a beta and alpha receptor agonist, which is used to increase the heart rate, contractility, and blood pressure. We then have drugs that are classified into uppers and downers. First, we'll look at the uppers. These are things like atropine, ephedrine, and adrenaline. These drugs are all involved in increasing the heart rate. Atropine increases the heart rate, ephedrine increases the heart rate, contractility, and blood pressure, and adrenaline increases heart rate and contractility. Downers are used to decrease the heart rate. The betalol is a classic example and is used to control hypertension and tachycardia. The drugs are labelled according to a colour-coded system, and this is used to both reduce errors and to increase productivity. Different drug classes have different colours. Purple is used for the uppers, such as adrenaline and ephedrine. White is used for antibiotics, and peach is used for antiemetics such as metoclopramide and ondansetron. Green is used for drugs that increase the heart rate, such as atropine and glycopyrrolate, and blue is used for opiates, such as remifentanil, morphine, and fentanyl. Orange is used solely for midazolam, and red is used for muscle relaxants such as rocuronium, atracurium, and suxamethonium. Yellow is used for induction agents. These include drugs such as propofol, which is the most common induction agent, and ketamine, which is used in trauma and in the forces. And finally, there are the extra stickers that are used for labelling things such as arterial lines and central venous lines. You have reached the end of this video. Thank you for watching.